Hi, everybody. Welcome back. We are going to be talking about pediatrics today. And I love this topic. I'm passionate about kids, and I want you to be very good and as comfortable as you possibly can be when you are caring for children. So, the first thing that I want you to know about pediatrics, we all get scared. We all get scared whenever we're called out to take care of a kid. And part of that is because most of us, unless we happen to work in a facility that specifically is caring for children, we do not get very much access to taking care of sick and injured kids. That's number one. We just don't have enough practice with them. Secondly, kids aren't supposed to die. And so that it kind of elevates this level of a trauma response inside of us. We get all nervous and excited, not in a happy way, when we know that we're on our way to take care of a child. So I just want you to know that if you're nervous about learning about taking care of kids, if you're nervous about going out and actually interacting with children, we all are. Okay, it's quite normal to feel that way. So just know that to begin with. I'm going to run through some things that are typical things that you really do need to know about taking care of little kids, and even all the way up to teenagers and 20-year-olds. Okay, I'm still a big kid myself, so maybe you can even use some of these things on me to help calm me down and comfort me. Hopefully, you never need to, but you never know. So to begin with, you need to know that children, pediatrics, are not just small adults. They're not just little mini versions of us. We like to think that, but there's actually quite a few things that are different about pediatrics. So they're not just little adults. We're going to learn some different things anatomically. We're going to talk about their responses, the way that their body responds to trauma, to shock. And so that's going to help you in knowing how to better take care of them. Once we learn how to take care of them, then you're going to be better equipped. You're going to feel confident. You are hopefully going to take away some of the tools that I give you and put those in your bag of tricks. And so whenever you're called out to take care of a pediatric kid, you'll say, well, I have the Pediatric Assessment Triangle. That's something I don't use on adults. I've got my Broslow tape or the hand Tevi system. I've got all these great tools at my disposal that I can use to help me be a great care provider. And some of the things that are provided for us make taking care of kids a lot easier. So just know that there are things coming that I'll teach you about that are going to help you to be great at this. So know also that when you have a child, I'm just going to hold up this cute little baby that I have. Okay, this is my little newborn baby that I've got. I've had this little teaching baby for about 26 years now. So if you're taking care of a small little person like this is not your only patient. Okay, you also have a mother and a father and maybe siblings or grandparents, a babysitter, who knows. You have other people that are going to be involved in this little person's life, and they are going to be your responsibility as well. You've got more than just this patient to take care of. Okay, so a big part of our role is in not only taking care of the patient that's the most important right now, but in making sure that everybody around you is feeling confident and that they know that you've got them. Okay, that you're doing the best that you can. Don't just leave people to the side without addressing their fears and their concerns. And so if we can keep a parent or whoever that caregiver is that's with the child, if we can keep them calm and we can give them reassurance and let them know we've got this, we've got you, we've got your child, we're doing the best that we can, and we know what we're doing because you all work very hard and you study hard and you practice a lot and you are excellent at your skills. When you can relay that to family members and they calm down, children calm down. So we want everybody to just take in a deep breath, let that out, and slow everything down. Doesn't mean that we're not aggressive in our treatment, but it means that we're going to think calmly and we're going to respond proactively and with a lot of confidence, but in a calm manner. Okay, that's going to help everybody in the situation, including yourself and your partner, everybody else around you. If the parent or the caregiver is agitated at all, children feed off of that. If you are nervous and anxious, they're going to feel that and they will respond to it because they're just kind of like horses. They can sense, or dogs even, they can sense when you are upset or scared or nervous. Kids are the exact same. You cannot lie to them. They know something's up. Okay. They might not know exactly what's going on, but be real. Okay. Be very professional and be sensitive to people. So some of the things that you need to know is just kind of where the breakdown is, because we clump pediatrics. We just say we're taking care of a pediatric patient. Well, pediatrics, from the time that they're a newborn baby to the time that they are an adult, there are a lot of changes that take place. And I'm just going to show you a picture right now of my children. This picture was taken 12 years ago. I've got this little baby right here. He just turned 12 yesterday, so this is a while ago. And my oldest, so I've got a baby that's just a few months old there, and I've got a toddler, and then I have a couple of, I'm trying to get my finger the right way, a couple of school age kids here, and then I have this kid right here who was 12 years old at the time that this picture was taken. So I kind of had like all ranges of children, but they're all so different right here, right? So when we talk about pediatrics, we're talking about having to deal with kids that are all these different ages. They're going through different things. Their bodies work differently, and it's important for us to really know and understand how to take care of each one of them. So first of all, we've got an infant, and an infant is from birth to 1 year of life. Okay, that they're just all in their own category, infancy, birth to 1 year. Toddlers are 1 to 3 years. Preschool age kids are 3 to 6 years old. School age is 6 to 12. And adolescents are 13 to 18 years old. And we're just going to run through basically what each of those categories looks like because they're so different. So in an infant, they actually are considered a neonate. And a neonate is just another medical term for a newborn baby. Okay. Newborn baby is 0 to 28 days, but we're just going to say that it's the first month of life. So that very first month of life, they don't do very much. They eat, they sleep, they poop, they just want to be held and loved and kept warm, and they're just snuggly and beautiful and wonderful little creatures, right? But they're pretty much just kind of growing and sleeping, and that's about all that they're doing. And so even up to about 2 months, they spend most of their time just doing that. They can sense different things as far as smell, the way that someone holds them. But if I were to hand my newborn baby, okay, got this little newborn, and I hand this newborn off to a complete stranger to this baby, I wouldn't do that, right, with my own child. But if I were to take this baby and hand this little person off to someone that they don't know, they've never met them before, never heard their voice, they would still stay calm and they would be happy as long as that person was holding them correctly, making them feel secure. They don't recognize that that's a stranger. Okay. So that's normal behavior. It's important for you to understand what normal is so that when you see the opposite of normal, you recognize there's something going on here. Okay. So they don't know who strangers are. Crying is the way that they're able to tell you that something's wrong or that they need something. They're not able to tell you, my tummy hurts. So instead, they cry. And then you got to try to figure out, what is it? Do they need their diaper changed? Are they hungry? Are they tired? Are they cold? Are they warm? Or are they actually in pain and there's something else going on there? If you have a small child, an infant, or even a small child, but especially an infant, if they are crying and no one can console them or calm them down and make them feel better, that's a big sign that something really is wrong and they probably need to be checked out and they may be sick. So that might look like, mom knows how to calm her baby down. She knows how to feed them. She can kind of read the cues as to when they are tired, when they're hungry, when they need a diaper change. And the caregiver does all of those things. They do everything that's normal that this baby needs, and they've met all of those life needs to comfort and calm this baby, and they're still not consoled. Something's wrong there. Okay. About 2 to 6 months. And you know what? this first year of life, and even not just the first year of life, but growing up and even throughout your entire life, people reach different stages at different times. These are just textbook answers. Of course, there are going to be some overlap with these textbook numbers. Okay, this is just the textbook answer. Uh, but around, a couple months to about the first, 6 months of life, um, these little people should be able to make eye contact with you. And they might look a little more, and I only have these little mannequins here. I don't have a baby anymore, but uh, they might be a little bit bigger like this, okay? So they should be making eye contact with you, and they should even be able to make eye contact with people that are not sitting directly in front of them, just a few inches from their face. And if they're not doing that, uh, they're not able to look at someone and track them and watch what's going on around them. That's not really normal. So if they're inconsolable, if they're really irritable, then that can tell you that something's wrong and they may actually be very sick. Okay. Because again, they're not old enough to talk to you. So you have to read the cues and know what's normal behavior versus not normal so that you know how to go about your assessment. Okay. And it might also be another sign that they may have some kind of developmental neurological delay. They may not be on track with normal progression of developing. Okay, so between 6 months and 12 months, then when I start handing them off to a stranger or even someone that they know but they don't know them very well, typically they're going to not be very happy about that. Sometimes they don't want to be separated from mom or dad, so they have this separation anxiety. Okay, and and that's pretty normal for kids to say, no, I don't know that person, I just want to stay where I'm familiar, where I'm comfortable. Don't hand me off to a stranger. So even in that first year of life, there are a lot of changes taking place. When we do an assessment on an infant, we're going to, first of all, this is with kids in general, we're going to do an assessment from a distance first before we ever even get close to them, before we touch them, before we try talking to them. We are going to open our eyes, open our ears, open up all of our senses, and see what's going on around us, see what's going on around the child, and how are they behaving in their environment, and is it normal? Okay. And if you don't know if something's normal or not, you can always ask the person that's with them. Most of the time, children are going to be with a caregiver that they are familiar with, and that caregiver is familiar with that child. So ask, are they behaving normally? Is this their normal? Okay. And then they can tell you, no, they're not acting normal today, and this is why. Or, yeah, this is how they act all the time. Okay, well, then why did you call 911, right? But then they're going to tell you. So if you can, if you can at all, if you have a caregiver, if you have, let's say that you've got mom there, and mom is holding the baby, okay, and we're going to say, this baby's 6 months old, so they're getting into that stage where they don't really want to go to a stranger, especially me walking in with my uniform, my badge, my stethoscope, my bags, my partners. I mean, we kind of look like cops, and even small kids are like, wow, what is that? Okay, so if I walk in and I've got a kid who is going to recognize that they're being handed off to a stranger, I want mom to keep holding that baby. I'm going to have her or whoever the caregiver is help me out. I am a big fan. Not everybody is, but I am. I'm a big fan of having family members help me. I can put people to work and have them here, hold this and talk to them and what works for them. And will you help me out here? Because I want them to keep this child very calm for me. I want this little person to not be traumatized by what's going on, even if we don't do anything invasive. I want them to have a good memory and to be happy. I don't want to cause pain. I don't want to cause trauma. So let's have mom or dad like stay there with us, and whatever's making the kid happy, as long as the caregivers are helping you and they're not hindering what you're doing, keep them there and ask them for help. Um, so we can give them comfort with a blanket, with a toy, just even with the presence of the person that they know. If you have to do anything painful, or anything that might be shocking to the patient, try to save that as much as you can. Try to save that for the end of your assessment. We want them to stay happy as long as we possibly can. Okay, and go through your assessment as quickly and efficiently as you possibly can. We don't want to drag this out. You can't really reason with a baby, so they're not going to understand why you're taking forever to do something. So just get in there, get it done, get out, make them happy again. Okay. And if you can explain, not if you can, you should be explaining to the caregiver, whoever's holding this baby, you need to explain to them, this is what I'm doing. And I'll tell you, me as a mother with my children, whenever anybody wanted to do something with my children, healthcare providers included, I was very protective and I wanted to know exactly why do they feel that they need to do that. And it was always very helpful when I had a caregiver that was willing to explain and say, well, this is really important because, and you can use that as a teaching moment for parents. And then they learn more about their kid. They learn more about how the human body works and what to watch for in the future. So we're teaching people too, okay? But give them a heads up of what it is that you're going to do. Okay, moving on to toddlers. So toddlers are fun. They're adorable. They're also difficult sometimes. I love infants because you can kind of get in there and play with them and make them giggle and laugh. And as long as you get those basic needs met, they're pretty happy. Toddlers, however, about the time they turn like 11, 12 months, after that first birthday, they're in that toddlerhood. And a lot of times you hear people call it the terrible twos. Well, I think terrible twos really last between 1 and 4 years old sometimes. But really 1 to 3 is our toddlers. And the thing that makes them a little bit more difficult and interesting at the same time is they want to be independent. They really do. They want to do things by themselves. They want to get their own drink. They want to get themselves dressed. They want to play with the toy that they want to play with. They're trying to show you that they can do things on their own and they don't need you to baby them anymore. And so often it's difficult to communicate with toddlers because they want what they want. And you can't really reason with them. You can say, you can't have that treat yet until after you've had your dinner because I want to make sure that you actually eat something nutritious before I give you the treat, right? And they don't care. They just know that they want the treat, and you let them have the treat sometimes. Why can't they just have it right now? And you trying to explain the reasoning, it can just be chaos. So it can be difficult to interact with them because you're not going to be able to reason with them very well. So you just do the very best that you can. And because they are mobile and they're kind of newly mobile, they're going to have some injuries that you might see that you probably won't see on most other patients. They're starting to walk and run and climb up and down stairs, and they're probably getting pretty good at it, and they're gaining more independence, and they have more confidence in what they're doing. But that also means that they fall down, they hit their heads, they're just at the right height where their head might hit the countertop in the kitchen, or so they're going to have bumps and bruises where they're falling, and they're just learning. Okay, they're learning how to walk, and they're going to have some signs that they're learning how to walk because they fall a lot, which also puts them at a greater risk for some things that can be very dangerous for them, like drowning and falling down the stairs, things that we'll get into a little bit later on in this lecture. They're also not just drinking milk anymore. Obviously, before the age of 1, they're eating other foods too, but they are grabbing foods on their own and really finding things and putting everything in their mouth. And infants and toddlers, they explore by grabbing onto something. Okay, I'll just take this little toy right here. They will grab onto something, and the way that they explore it, hopefully you're not doing this anymore, right? But I'll pick this up and I'll look at it and I'll turn it around and I'll squish it and I'll feel it with my hands, and I might throw it up and down and play with something with my hands and check it out with my eyes. I might even smell it. But a small child, an infant or a toddler, what do? They pick up an item, and where does it go? It goes right in their mouth. Uh, and they chew on that. And then they look at it, and then they chew on it again. And orally, that's how they learn about things. So these little infants and toddlers are at a huge risk for choking hazards. Okay, so we really got to watch that and always consider, especially if there's any kind of airway obstruction or breathing problem, could they have something in their mouth? And did big brother or sister want to help feed their little sibling? And so that happens quite a bit. So watch out for that. When they're about a year and a half ish, like in the toddler age, a lot of times they're clingy and they will literally hold on to mom and dad. They'll hold on to mom and dad and they don't want to let go and they don't want anybody to take them away. And they'll run up and grab their leg and hang on to them. And I'll tell you a quick little story. Okay. So this is Rachel as a toddler, me as a toddler. I was at an Idaho State University football game with my parents, and their mascot is a tiger. And apparently at the game, there was the mascot going around the stadium, and apparently I didn't watch the game at all. And this tiger was walking all around the stadium. And my parents tell me to this day they thought it was so funny. I was terrified of that tiger. I was terrified. And apparently I watched the tiger all go all up and down all the aisles of the stadium, all the way around. And it finally came around to us. And as it got closer and closer, I was on my dad's lap. And my dad says I kept clinging to him and I was gripping tighter and tighter as that tiger was getting closer and closer to us. And I was starting to scream as it was getting closer. And then my mom and dad said that I started climbing up my dad and I was just holding on and would not take my eyes off of that thing, this giant man-sized tiger. And the tiger came up and was trying to tease me with the tail, and I was terrified. And that's a toddler behavior. I was clingy, I was afraid, and toddlers will use the people that they know for safety. So they'll cling on. There's a weird little toddler story for you. Normal behavior. Okay. Well, I think it was kind of normal. I'm not really normal, but there you go. So some toddlers are going to have stranger anxiety, just like that story that I told you. Now, some of them are not going to be that way, and a lot of it depends on the personality of the child that you're interacting with. Okay, but they do feel more comfortable in a normal situation. They feel more comfortable and confident with their family members that they know. A problem can be that they can't really describe pain. As a toddler, they might be able to say, "Ow, I hurt," but they might not be able to tell you, when we talk to adults and we say, describe the pain for me, just tell me what it feels like. A toddler can't do that. They might just say, I hurt. And so things that you might be able to say to them are, can you touch where it hurts? Can you point to where it hurts? And they might touch their ear because they might have an ear infection, right? And so they might be touching their face or pointing to their ear. You got to simplify it, make it very, very simple for them. Okay. They can be distracted. And so I love to use things to distract kids. And some of the things that I use are like this little toy that I already showed you. I'll have toys ready for kids to play with. And in every ambulance, fire truck that I know of, there are fun little toys. We have stuffed animals to give to kids. Okay. And this can be such a great thing. It can be a distraction for them. And we have those things to give to the children. We don't take them back. Once you give a kid something, if you tell them, I'm going to let you have this, then they get to keep it. And they're going to love that. And that will help them. Other things that I like to do, these little pen lights that we have, they're only like $1, right? And I will use things like this and I'll say, do you want to see my really awesome flashlight? I've got this really cool flashlight. And I need to look at some different things. And I might play with the flashlight and use that in my assessment and say, you help me out and I'll let you keep this. It's only $1, right? So I'll even give them a little prize for being a great patient and for helping me. So I use stuff like that. And even when I'm assessing them, I might take things like my stethoscope and I'll, because a lot of times kids don't like a child unless they have a nurse or a physician or an EMT or whatever for a family member. They're not going to know what this thing is. They're just like, okay, what are they going to do with that? And so I'm going to, if this is a time when I'm going to use a caregiver, um, a parent or someone to help me out. Okay. So I'm going to maybe take my item and say, this is just something silly that I do. You can come up with your own ways to make this work for you. But I need the kid to cooperate with me, right? So I may say, this is a really cool tool that helps me to see how strong your heart is, right? And I can hear you breathing in this. And this is so cool. And and I'm going to listen to lungs. Do you want to watch me? You want to watch how I do it? And I'll put these in my ears, right? I'll put them in my ears, and then I will take this and I'll even show them on me and I'll say, watch. And I'll breathe and show them exactly what I want to do. And then I'll say, Mom, do you want to do it? And I'll get mom involved or dad involved or even a big brother or sister. And then I'll show them and I'll say, watch, mom's going to do it. And then mom gets excited and she's like, wow, that's so cool. And then I'll say, okay, are you ready for your turn? And and I will do that on the child. I might turn it on to the pediatric side, right? Because they have smaller bodies. And I'll listen to their lungs. And I may even tell them, do you want to listen to mom's lungs? Do you want to hear her breathing? And I'll put this little thing in the little kid's ears and I'll let them listen to mom. And mom can even hold this and they can help each other. And then it's going to be the kid's turn, right? So you can do little things to try and help them see that this isn't scary. It doesn't hurt mom. She's fine. She's still happy. And it's going to be their turn. So you can try and do things like that. Distract them. When we begin our assessment, this is the one, not the one, but this is one big thing that's different about a pediatric assessment versus an adult assessment. When you do an adult assessment, a physical assessment, we tend to go straight for the chest, right? If this is a medical assessment, we're going to go right to airway and circulatory system. Or if we're doing a rapid scan, I'm going to touch you from head to toe and you tell me if anything hurts. And so I'm going to start touching right at the head. Okay. And then I'm going to work down the body. But when I've got a child, a small child, teenagers can get that, right? Even some school age kids might understand that and be okay with it. But when I've got small children, if I just went straight for their head to touch their head from head to toe, they're going to freak out. Okay. So what we really want to do is we want to go in an opposite direction. And that's going to look like I'm going to touch from a place that's non-threatening, and that would be their feet. And sometimes I might even start at their hand, just touching their hand to begin with. Touching hands and feet is not really threatening to a kid. But I'll start at the feet and I'll work my way up and I explain every single thing that I'm doing to them. And sometimes I kind of tease them a little bit and I try to get them laughing and I distract them and I make sure that they've got their toy and that mom and dad are involved and that this is a happy, safe, okay thing to be happening. Okay. And then by the time you get up to their head, then it's like, wow, you can talk about, oh, I'm going to check out your ears, and make fun little comments to them and just try to make that a happy experience for kids. If they're crying and crying and crying and crying and you can't get them to stop, mom and dad can't get them to stop, again, this is a repeat, but that's probably a sign that something's really wrong. And it may be physical, it may be emotional. That's part of our assessment is trying to figure that out. So with our preschool age kids, okay, so now we're moving into children that are aged 3 to 6, okay, they're preschool age. The foreign body airway obstruction is still a really big deal. We still need to be aware that they can have airway obstructions quite easily. When we are doing an assessment on these kids, they have the ability to understand a lot more. So I'm going to be able to reason with them a little bit more and tell them, okay, I need you to sit really still and be really quiet for this part, okay? And then I also am able to say, this is what I need you to do. And they can follow directions a lot better. I can ask them, Like, what does that feel like to you? Talk to me about that. Tell me where it hurts. And they have a lot more words in their vocabulary. Their verbiage is expanded quite a bit. They're learning so many words every day. And so they can give you a better explanation of what's going on. We're still going to have to talk to mom and dad and find out more history about all of these children, okay? But try to still keep it very simple, keep it direct. Don't get too sidetracked, okay? Just keep it simple as you can. And preschool age kids are really fun because they have these huge imaginations, and you may even be able to use their imagination to help you along. There are times when I'm going to, this is just this is what I tell kids. Okay, I'm just getting real with you here. When I'm going to take a blood pressure on a kid, okay, I don't have my large adult size cuff. I've got a smaller cuff that fits a pediatric size arm. Choose the right size cuff. Uh, and I'll wrap that. I'm going to put it around the kid's arm, and I'll even tell that child, "This is my cool tool. This is so cool. You're not going to believe this, but this tool is going to help me know how strong your muscles are." And kids love that. And so I'll put it around and I'll say, it's going to give your arm a big hug. Okay. So it's got to hug your arm really tight, because we all know that getting your blood pressure taken can be uncomfortable. For a kid, they're not going to understand that, yeah, it's going to be painful. Just suck it up. Can't really tell that to a kid. So I try to play with their imagination. It's going to show me and tell me how big and strong your muscles are. You ready? Let's find out how tough you are, how strong you are. And then I'll take their blood pressure and I'll be like, holy cow, you are strong. Like, show me your muscles. And then they'll be like, yeah, they show me their big muscles. So have fun with it. Have fun with it. Help the kids to have fun with that too. A big thing to remember with kids is you never ever want to lie to your patients. Okay, don't lie to kids. They are going to be able to read that a mile away. They'll know if you are not being honest with them. So don't lie to them. And if a child says something to you like, is that going to hurt? And you have to start an IV, you better tell them that it's going to hurt. And I don't say things like, yeah, this is going to hurt. Like, it hurts really bad. So hold still. I'll say something like, it pinches a little bit, it might feel like, yeah, it just feels like a little pinch. And then I come up with a way to describe it where they might be able to relate to it, but it isn't as scary. Okay. So, but don't lie to them. Don't say, no, this doesn't hurt. And then as soon as it does, this is what happens. Their trust in you is gone, and they're not going to believe anything that you say. So always tell the truth to them. If a kid says something to you like, am I going to die? Which is really interesting. Children tend to believe that the worst possible thing could happen because they have a stubbed toe, and they worry that somehow that's going to affect their body and they're going to die from it, right? You're going to be great. Like, you're doing so well. No, you're not going to die. If it's really bad, you may not want to say, your chances don't look so good, but you can always say, hey, we got this, right? We're doing the best that we can, and you're doing great. Here, hold this pen light and check it out. Like, use that flashlight to look around. Okay. And so distract them as much as you can, but never lie. If they have wounds, kids don't like to see cuts, even if they're just the most minor thing. Get out your Band-Aids. They're so cheap. Just get out the Band-Aids and cover up the wounds. Put a blanket, put a dressing over things, so that kids are not seeing trauma, because even if it's insignificant, it can be upsetting to them. If they don't see it, they don't think about it as much. So always, also with your children, make sure that you are protecting their bodies. And what I mean by that is protect their modesty. Some kids, and this is all based on personality, some children will strip down naked and they love to run all over the place with absolutely nothing on. And they're just quite happy to do that. Okay, they don't care. There are other children that want to be covered, like, from here all the way down to their toes. And so you really need to be respectful. Just plan on keeping their bodies covered. If they keep uncovering themselves, that's one thing, but be as respectful as you can. If you need to expose their belly to check out their belly or their chest so you can listen to lung sounds, expose it and then cover them back up. And then move to the next section of the body, okay? just to protect them. Okay, when we get into school-age children, these are kids that are ages 6 to 12. These kids start to really gain an understanding of what death is and what death means, and the fact that death is something that people and pets, right, they don't come back from that. And so that's pretty significant for that age group of children. They're starting to understand that there are consequences to things. Whereas when they're younger, a toddler, mom might say, or dad might say, do not reach your hand up on the stovetop. It's hot. They're like, okay. And they reach up there anyway, and they put their hand on the stove, and then they get burned, and they're like, ow. They don't understand yet that people that are older and wiser than them are trying to protect them, and they're trying to explain, look, there are consequences to your actions. But when you get into a school-age child, 6 to 12, they get it. They know that, okay, I'm going to cross the street. I need to look both ways, because if a car is coming or somebody on a bike is coming, I could get hit and I could get hurt. There are consequences to things. So, and they understand death. So this is the age when your assessment may start to look more like an adult's assessment, where you can say, I'm just going to touch down your body and see if there's anything else that's hurting that we missed before, okay? And you might be able to start at the head. And again, you've got to go based on their body language and how they seem to be reading you and you're reading them. You may still want to start at the feet, but most of the time, they're going to get it. They're not going to freak out because you touch the top of their head first, okay? So read the child, kind of go with that, but you can start treating them a little bit more like an adult. And we're not just going to talk to the caregiver. With the younger kids, we're talking to them. We're acknowledging the smaller child, but we're also talking to the caregiver a lot. We're trying to get a lot of information from the caregiver. The older the child becomes, when you get into that school age, we're talking mostly to that child. We're asking them the questions. We're kind of gaining this rapport with them. Tell me about school. Who's your best friend? What kind of video games do you like to play? We're trying to make some kind of connection, find out what it is they're interested in, and ask them the questions. So tell me what that feels like, and how long ago did this start? You can ask many more questions to your school age kids, and they'll be able to answer you. They're probably a little bit more familiar with a physical exam too. They've probably been to a doctor for a checkup, and they get it, that you are a healthcare provider, and you may need to explain to them, I'm here to take care of you. Yeah, I take care of the injuries, and if you're upset to your stomach, if you have a headache, whatever those things are that are going on, that's what my job is. I'm here to take care of you, okay? So we also want to give children choices as much as possible. And choices that I'm talking about are not choices like, I hear a lot of people say things like, so is it okay if I take your blood pressure? And what do you think the child's going to say? I have a choice? No. Nope, you're not doing that. Well, they don't really get a choice when it comes to you doing an assessment that needs to be done. The choice might be, I'm going to take your blood pressure. Do you want me to do it on your right arm or on your left arm? Right? That might be the choice. Or I need to take care of these certain things. Do you want me to start on your toes, or do you want me to start on your fingers? Okay. So things like that, where they can get a choice, it helps them to feel empowered and they're more part of the process. And the whole reason for that is that we want them to be cooperative. We don't want to traumatize them. And so we're going to give them choices. Make sure that the way that you ask your questions gives you control as a healthcare provider, not the child, okay? And at this stage, they really can start to understand the difference between pain that they feel in their body because they fell down the stairs versus pain that they're feeling in their heart because someone hurt their feelings. They're understanding that there is a difference between emotional pain and physical pain, which is really good. They understand, I feel really sad because whatever, A, B, C, or D happened. And that can be very good for us to be able to reason with them and explain what's going on. Give them simple explanations. If they ask you a question, you do not need to use medical jargon with anybody. Okay, do not start talking about, well, you're hypotensive, and so they have no idea what you're talking about. Okay, a lot of adults don't know what you're talking about. So just say, yeah, your body looks a little bit sick. It's kind of sad right now, so we're gonna fix you up. Okay, we're gonna do these things to help you feel better. And you can always ask advice of the parents. What is it that helps your child feel better? Is there anything that they like to talk about? Anything that we should not talk about? And help get the parents involved so that you're having that child have a good experience, and that they're cooperating and allowing you without a fight to get done what you need to do for them. So then we move into adolescence, and I think adolescents are the best. I really do. I just, besides the babies, I love babies too, but adolescents are a lot of fun. Okay, and they physically are getting into that stage where they are like adults, um, and and this is like our 13 to 18-year olds. Okay, they're more the same size as adults. Their bodies are acting more like adult bodies. Some of them just look like they're already adults. You don't even know that they're still a pediatric patient. So they're similar that way, but often they are still emotionally children. And the really interesting thing about our brains and the way that we think and our emotional states is we can bounce around. It's kind of like the 5 stages of grief, right? You can bounce around all over the place at different times. Well, our emotional age can do the same thing. You might take care of a person who is 18 years old and they're acting like a 6-year old. They're throwing a tantrum and they want their way and they're making it known, and you would think, wow, they're in an 18-year-old's body, but they're acting like they're in kindergarten, you know. And some of that can be that they're in trauma. uh, there's lots of different reasons why people will do that, but just recognize that they can still act like children. And just because they're acting very mature and they're acting like adults does not mean that they are adults and that they can handle the same things that adults can. So you really have to be aware and conscious of that and supportive of your patient. Okay, that's what I'm trying to say. uh, I had a patient one time. This is another little story. I had a patient one time who was in a car accident, and this was a 12-year-old male, and he was in a pretty significant car accident. Uh, and he was with his mother and his father, and then there was him. So there were 3 individuals in the car, and his mom and dad were both in critical condition. And mom and dad had been transported to a hospital prior to him, and this 12-year-old boy was my patient, and he was not injured terribly. He had some cuts and bruises, but physically he was okay. But emotionally, this 12-year-old kid was very upset. Obviously, he's worried about his parents. They were significantly injured, and he knew that. You know, he's old enough, he's smart enough. He knew that it could be a bad outcome for them, and he was very worried about it. So I have this 12-year-old kid, and he was a pretty big kid. He was close to my size, uh, and and yet because emotionally he was so upset, um, he was acting like he was much younger than 12 years old. And I remember getting in the ambulance with him and trying to calm him down and holding his hand, and he really was acting like a 5-year-old. Okay. And we get in the ambulance, and I got into the cabinet and I got out a stuffed animal. And I and normally for a 12-year-old child, I wouldn't necessarily think about getting out a stuffed animal for a 12-year-old, because most 12-year-olds, if you were to give them a stuffed animal, they'd be like, I'm 12, I'm not 6, right? But this guy, he I just thought, I'm just going to try it. The worst that can happen is he can, scoff at me. Well, I got out a stuffed animal for him and I said, here, why don't you hold on to this? And he took the stuffed animal from me and he pulled that in next to him. And this boy just held on to this little stuffed animal and he was petting it. And he really was just like a little 5-year-old in that moment. And that stuffed animal helped him to feel better. and he held on to it. He held tight. He wouldn't let go of it for the remainder of our transport. Even later, as we were leaving the hospital and he was in the ER bay, he was still holding on to that thing, and it brought him some comfort. So emotionally, people can be all over the place. Okay. Um, Adolescence is also a time when people tend to take a lot of risks, and and the significant thing about that is people are experimenting and trying to figure out who they really are and who they want to be and what do they believe, what do they not believe, regardless of how they've been raised, what mom and dad have taught them, what their friends are into can have a big influence on them. But even outside of their friends, they might see all kinds of different things going on, and they want to know what certain things are about. So people tend to take more risks. They take risks with driving fast or driving crazy. Okay. They take risks with trying recreational drugs. They want to know what that feels like. I'm not saying all people do this. I'm just saying this tends to be a trend, something that we see that happens. So they like to experiment with alcohol and drugs to find out, what does that make my body feel like? Do I like this? Do I want more of that? They tend to experiment sexually. And so they want to know about sexuality, and they're exploring all of that. They tend to take a lot more risks. Maybe they're going to go to the lake and they're more willing to jump off the cliff, even though there are signs saying, this cliff is really high, please do not jump. They're more willing to try it. They tend to not have any fear. They don't believe that if there's a death that will occur, that it's really going to happen to them. And that's just something that typically is with this age category, 13 to 18. And so we tend to see a lot of accidents, a lot of significant MOIs with children that are in this age group. And it's really interesting because it tends to be males who are maybe 17, 18 to 20, 21 year, maybe even 22 years old. Like there's this age range, and it typically is males that tend to take more physical risks. And we see a lot more drowning incidents. We see more car accidents because they're just, they believe that they're invincible. Nothing bad is going to happen to them, and they get a thrill from different things. So it's not always just males, but that tends to be the majority of what we see. So, but the cool thing about adolescents is they are very complex. Their brains are very smart, very, very intelligent. And so you can explain things that may be difficult to understand, but if you explain it well, if you're a good teacher, they're going to understand. And that's pretty cool. So allow them to be involved in their care. Tell them as much as you can tell them about what's going on without overwhelming them. And if you have an EMT that is the same gender as that patient, that may be the best person to take care of them. It's not always the case. It's not always possible, but choose the EMT that they are the most comfortable with. Okay, EMT, AEMT, paramedic. Try to get the person that they seem to be connecting with the best to take care of them. Allow them to speak openly and to ask questions. And this really can be a good teaching time. And kids this age tend to have a lot of questions, and depending on why you're there, they may be willing to ask you questions that they're afraid to ask parents. Be open about stuff. Do not go into details that you do not need to go into, but answer them honestly. Give them factual information, and yeah. And so you may have female patients that are pregnant, and you've got to ask the tough questions. If you ever have a patient that you feel may be pregnant, you are questioning that, you think that this is a possibility. If you have a female that's saying that she has lower right abdominal quadrant pain, you need to ask, is there any way that you could be pregnant? And most of the time, if you get a 15, 16-year-old, they're going to say, no, not me. I'm not pregnant. Okay, are you sure? You kind of need to go there and make sure that you really cover that and that you know. And this is a time too when you may want to have your partner say, will you take the parents and go have them like fill out some paperwork and ask some questions of the parents? you we all know that teenagers are not, they're more likely to be honest and tell you the truth if parents are not in the same room, especially if it's a really sensitive topic. And you don't want to be alone when you're doing that. You want to try to have a witness there, have someone else there with you, but have another person on your crew take parents out of the room so that this patient of yours feels like they have the freedom and the safety to say what they really need to say. And you need to get to the bottom of what's really going on, what really happened. Could you be pregnant, or is there no way because you are not sexually active, or is it possible? And or do you have any recreational medications or not recreational in your system, right? I need to know what's in your body so I know how to take care of you. Okay, we have to have those really candid, hard conversations. And um, yeah, yeah. So I think that's where we're going to stop our part one of pediatric assessments. And so I'll be back with part two, and we'll talk about anatomy and physiology and what the differences are and what you need to know about children versus adults. Okay, I'll be back.